Hello, today we are speaking about occipital-cervical malformations in children and how to fuse them, what are the indications, the technique, and the results. So, craniocervical instability is a common occurrence in a large number of rare disease, and it tends to aggravate with growth. It provides a risk of neural compression, and it has a major impact on the posture, on gaze, feeding, breathing, all the functions that have the head in all vertebrates. So, and we have to take in account the imperatives of stabilization, decompression, and reduction. So what is the rationale for surgery? Whenever possible, we have to wait until the growth is until the child is has grown enough, but it's not always possible, as we shall see. The compression is mostly anterior, so should we use an anterior approach? As we shall see, it would require very often a circumferential fixation, so we do not escape a posterior fixation, and it can be complicated in case of oropharyngeal or tracheal malformation. So is it possible to use a posterior approach only? And this is this option that we shall try to defend in the present lecture. And because very often we found that it was enough to stabilize and decompress durably the craniocervical junction and avoid an anterior approach. And also, we have complex craniospinal malformations with hemivertebrae, and sometimes it is possible to just bridge the abnormal level without putting screws or anything in this very abnormal vertebrae, which is a challenge. And also, we shall show that the occipital squama is really an excellent autograft material. It does not cost anything, and it looks as if it was made on purpose for our grafting. So first, which disease are we going to treat? As I said, there is a large number of rare disease. So we will base our presentation on a study I did in my patients in Lille. So these are 17 patients operated over a 15 years period. These are 7 males and 8 females, and they age from 8 months to 15 years. So these can be very small patients. The vast majority of them are syndromic, and very often they have an airway problem. So this has to be taken in account. And the presentation was very often pain and head tilt, and also very often neurological deficit, even tetraplegia in 6 cases, and sleep apneas and mixed nerve palsies. So the main dislocation was anterior in 7 cases, lateral in 5, axial in 3 cases, and multi-planar in 2 cases. So these are a sample of all the different rare diseases that we can find. I guess many of you have never heard of some of these diseases. Some are more common, like Golden House syndrome or Currarino syndrome, but these lesions are very rare, in fact, in these diseases. And you also understand that many of these patients have other conditions, like the Hunter disease, for example. This patient could not be operated because of the airway problem. Down syndrome, they often have heart or digestive problems. And this little girl with the Jeune syndrome had a very severe thoracic dysplasia, as you can see. So what are the aims of this surgery? Is to provide, these are both morphological and functional. We need statural growth. We need a self-sustaining head without the support of a brace. For example, this child had 9 years and he has passed half of his life with an orthosis, and you see the results on the development of the maxilla and the mandible, which improved after he was weaned from his orthosis. And we need a horizontal gaze, and this is a little girl who had automandibular syndrome of Goldenhar, and this is the result we achieved in her. It's not perfect because she has a complex facial malformation, but it's much better. And before surgery, she needed the support of her right arm to support her head. And very often, the surgery aims at improving the pain because some of these patients can be very painful. So what is the timing of surgery? As I said, we try to avoid doing surgery too early because we stop the growth. However, it may require emergency surgery if there is a neurological compromise. This is a child who was referred at 5 years. He was tetraplegic, and when we see the X-rays done 2 years later, which were considered normal, they were not normal at all. And if we were able to see him earlier, he would not have become tetraplegic. It may be a semi-emergency if the patient is painful, if he has severe dissection compromising function, like the previous slide, and if possible, we can wait for growth. And this is a child who was seen at 4 years. He was almost, he has an almost straight spine, but after 4 years, he developed a severe tilt, and he was operated at that time. So what was the management? We do preoperative or intraoperative reduction, mostly intraoperative, but sometimes before surgery with a halo or with tongs. We use fixation rod plates in a majority of cases. 4 of them were not instrumented because they were too young. They were too small for the material we have. And grafts were used in almost all cases, mostly using the occipital squama or the iliac crest in 3 cases. And we did a postoperative immobilization, mostly with a brace, and 3 with a halo, and 1 did not need any immobilization. So the reduction, we do reduction in different planes. It is anterior-posterior. The aims are neural decompression, of course, often done in emergency, as I said. The aim is to settle the center of gravity on the lateral masses of the occiput to prevent progressive kyphosis. We use tongue, we use a halo. It can be intraoperative. It can be, we have to correct lateral inclination, like in this girl with the Goldenhar syndrome. The aim is to provide a horizontal gaze, but also to relieve pain and avoid the self-aggravating effect of gravity. And the means are we have to check the vertebral artery when they are so tilted, when the head is tilted that much, with the Doppler, with the angioscanner. We do a pre-op halo to correct progressively the deformation. We finish the correction intraoperatively by differential distraction on one side more than the other. And we do a protractive physical medicine management to avoid the recurrence due to further growth. And this is the result as I showed earlier. Axial rotation can be addressed as well. It is very often combined with other rotation, like in the cock-robin posture we find in torticollis, except that this is not benign torticollis, of course, and it has a crankshaft effect. It will it aggravates itself with the growth. We try to correct the axial settling. The aim is to provide neural compression, but also to provide some growth, like in this patient. And we can use preoperative tongue or halo or do distraction during surgery. And it can be a multiplanar correction, like in this complex cranio-cervical malformation. This way, we were able to provide a horizontal gaze, neural decompression, and a harmonious growth using a halo preoperatively and intraoperative correction with a distraction. So we have first to install our patients on the operating table. Sometimes we have to receive them in emergency and do an emergency decompression by placing a tongue under local anesthesia. It has to be placed just a little bit anterior to the occipital condyle so it can provide both axial traction and some lordosis. We can also put a halo crown in emergency and we have later some time to fashion the vest for the halo. The traction is about 10% of body weight. The number of screws in the halo depends on the age. The younger the child, the more screws you need to put. And we control the reduction by X-ray. If it is very easily reducible, that means that it is very unstable. And then we do, during surgery, a halo infusion or both. And for the management of this patient, we have to be very careful about the occiput because they very easily develop bed sores. So the positioning for surgery is prone in most cases. We can have to put some lordosis to provide reduction. And sometimes we, on the other hand, we may need to put some kyphosis to gain surgical access to the posterior aspect of the spine. We place the head on a horseshoe headrest. In some cases, we use a pin headrest then we have just to fixate in situ. That means we cannot do any reduction during surgery. And we may need to use the C arm or the O arm to control the reduction. But it can be very complicated to install the patient, as you can see on this picture. And the good thing with the occipital squamma is that we do not have to prepare a site for graft harvesting. And we do not use neuromonitoring, but some teams use it regularly, especially for the positioning. But in fact, I never regretted not to have used it. Then we do the intraoperative reduction. We can be done with tongs, like in this patient, under X-ray control. So we reduce the kyphosis by lordosis, but it will shrink the operative field. That means we have less space to work. So we may need during surgery to do some additional, to put a second spreader vertically to provide some kyphosis in order to gain access to the lamina and the occipital squamma. Then sometimes when we have gained some correction with a halo, we just place the patient with the halo on the operating table. We just remove the posterior rods. We do this kind of installation in highly unstable lesions. And of course, we cannot improve the correction during surgery. Anesthesia is a really complicated matter, and when you present these patients to the anesthetist team, sometimes they hate you to give them such complicated cases. They can have a heart problem, a pulmonary problem. These patients with a Hunter disease has had such infiltration of his tracheobronchial trees that it was impossible to ventilate him during surgery. He was not operandi. The patient on the right required selective ventilation of the two lungs by different ventilators. And you understand that these are very difficult patients for the anesthetist team also. Then we have to fixate the child. So which device can we use? We can use just graft and ligature, which is especially in very small children. I very often use the Vertex material, and sometimes I use the Virage material, which is sometimes superior. So the graft and ligature are the by default technique. It is the only possible technique in the very young, and it comes in complement to metallic construct, whatever it is. But it has a poor stability. It requires a brace or a halo after surgery. So we need a graft material, that is the occiput, which is very thin in small infants, and a grafting site, that is the laminae. So it's the by default technique, but it's better if we can put metallic construct. So the Vertex has the advantage of a very good cortical screws, which have a very good hold in the skull and hooks on the laminae. And we can use deported hooks on the laminae, which have a better lever arm construct. And the drawback is that the rods are partly conic, and it may be cumbersome in young children. And that's a good point in the village, that the rods are completely cylindric. And it has also some cranial implants which are deported, but it may not be so easy to obtain this material. Then, as I said, I would emphasize the interest of the autologous bone graft from occipital squama. Very often we have to do bony decompression of the occipital rim, but even if not, we have a very easily harvested bone graft from the occipital bone. We can cut bone flap, as seen on top right, and cut it in small chips, which are excellent bicortical cancellous grafts. So we use only one operative site for the for the surgery. We spare the ribs, the iliac bone, the fibula, and the muscles. And it is abundant even in the very young, but we have to be careful to preserve the site for implanting the plates on both sides. And as you can see on the picture, on the CT scan bottom right, the shape of this graft are perfectly adapted for the graft that we need to do. As I said, we can do some bridging fusion with hooks on the lamina that remain. So when the vertebrae are very deformed, hemivertebra, very dysplastic, missing laminae, we can do a bridging fusion. And we apply some graft between the fixed vertebra. And the stability is completed by the halo or Minerva cast. So what are the results? In the series, we had a good fusion in all cases. None of them required an anterior approach. 5 presented some recurrent kyphosis, but only one required another surgery. She was a very small baby at the time of operation, and we were afraid that the child would develop basilar settling, and she did, but she was asymptomatic, so we were thinking of doing another surgery, but we delayed. And while she was waiting, she developed a paraplegia, which was caused by progressive upper thoracic spine kyphosis. And we did another decompressive surgery from posterior lateral decompression, and she recovered her legs. So she had a very short cervico-thoracic spine, as I will show you, but she nevertheless went well from the neurological point of view. So it shows that these patients really require very prolonged follow-up. So the clinical results, the mean follow-up was 55 months, from between 1 month and 13 years, and the functional outcome was good in most problems regarding the motor problems, sphincter, spinal problem. The majority of these patients are very good autonomy for ambulation. Their autonomy score was mostly impacted by the syndromic context. And their schooling was special in half of them. That means that many of them had some developmental delay, but obviously the schooling problem were not caused by the cranio-cervical spine problems. So there are some unwanted effects of fusion. Of course, it sacrifices the mobility, but as you can see, the impact is really mild, and these patients are able to gain a very good autonomy. There is a stunted growth, but is it the result of the surgery or of the disease? Anyway, it has to be anticipated, and some information should be given. And there can be some progressive cervical lordosis by crankshaft effect, as I showed. And also, this is not well known, but you can see there can be very difficult swallowing in these patients, but because the first time of swallowing is requires some motion at the cranio-cervical level. You can imagine what our cousins, the reptiles, do when they swallow their prey. So this also has to be anticipated. And in small babies, as I said, we have to follow them for a very long time. There are some technical problems. There is no material for osteosynthesis. We just have to rely on bone graft and sutures. We need Minerva, which has to be very small and very well maintained. And the further growth can give this kind of results with a very short upper segment, while the legs look completely disproportionate when the patient becomes a teenager. So in conclusion, posterior decompression and fusion achieves a very good correction in the different planes and does not need an anterior approach. The odontoid is harmless in as much as the motion is suppressed. The occipital squama is an excellent autograft material, which is available from the same approach, but we need watchful and protective physical management and a very long time follow-up. I thank you for your attention.